Okay. Good morning, everyone. I am Dr. PRIYAMBADA SUBUDHI, and I am here to present a rare case of incidental diagnosis of gyrate retinal atrophy. I have no financial disclosure and no conflict of interest. Now, gyrate atrophy of choroid and retina is a rare autosomal recessive disorder resulting from the deficiency of the enzyme ornithine aminotransferase. It was first described by Fuchs in 1896 and is characterized by high myopia, typical retinal and choroidal lesions, early cataract formation, and most importantly, hyperornithinemia with levels as high as 10 to 20-fold above the normal. In this case, a 13-year-old girl was detected with bilateral myopia and prescribed spectacles during rural school health screening 3 years ago. Her distance vision rapidly deteriorated and she developed night blindness in both eyes 1 year ago, for which she was referred to our tertiary eye care hospital. The best corrected visual acuity in both eyes was 6/60 with minus 3.5 diopter sphere. There was no color vision deficiency in both eyes, and the anterior segment examination was unremarkable in both eyes. The pupil reaction and intraocular pressure were within normal limits in both eyes. The dilated fundus examination showed sharply demarcated areas of choroid and retinal atrophy in both eyes, sparing the macula with thin areas of pigment between those atrophic areas. Now, she was advised Humphrey visual field 24-2 in both eyes, which showed constricted visual fields. As the visual field in left eye was highly constricted, she was advised at 10-2, which also showed a constricted visual field. On fundus fluorescent angiography, the patches appeared as hypofluorescent with faint hyperfluorescent borders. The electroretinogram response was within normal range. There was a significant increase in serum ornithine levels, which was 646 micromole per liter. There was no systemic or intellectual abnormality detected in the patient, parents, or her younger brother. Now, coming to the differential diagnosis, we have two diagnosis of gyrate atrophy, that is choroideremia and myopic fundus changes. In choroideremia, it's a rare X-linked recessive disorder which is characterized by night blindness, visual field constriction, and visual acuity loss, which may confuse with gyrate atrophy. In advanced stages of the disease, resemble later stages of gyrate atrophy, but the well-demarcated round lesions observed in our patient are not characteristics of choroideremia. In myopia, patients with high myopia may present with peripheral clusters of atrophic areas or paving stone degeneration that may resemble the lesions seen in gyrate atrophy. But paving stone degeneration is typically found between the ora serrata and the equator, while in gyrate atrophy, the lesions are more concentrated in the mid-periphery. Now, the patient was started on high dose of vitamin B6, 300 milligram per day, and dietary advice about low protein consumption, that is an arginine-restricted diet, was emphasized. Now, gyrate atrophy is a rare progressive metabolic choroidal and retinal degeneration resulting from the deficiency of the enzyme ornithine aminotransferase mapped onto the short arm of chromosome number 10. The inheritance is an autosomal recessive pattern, and its main manifestation is a gradual loss of vision, night blindness, and tunnel vision. There is subsequent development of posterior subcapsular cataract by the second decade, progressive constriction of the visual field, and eventual loss of central vision in the 4th to 5th decades of life. A 10 to 20-fold rise in plasma ornithine levels is characteristic. The administration of pharmacological doses of vitamin B6 is an established procedure, as ornithine aminotransferase is a B6-dependent enzyme. Welleber et al. Reported that 3 out of 7 patients responded to oral B6 supplementation with over 50% reduction of serum ornithine. As ornithine is synthesized from arginine, an arginine-restricted diet may decrease the plasma ornithine levels to normal values. This case emphasizes the importance of correct diagnosis, screening of parents and siblings, and early institution of treatment in gyrate atrophy, as it slows down the progression of retinal degeneration and prevents complications of the disease. So my take-home message would be school visual health screening, prompt referral, and awareness on willingness of the parents are essential for the early diagnosis and treatment of this rare genetic disorder. These are my references. Thank you.